Hello there, happy Friday. Friday lunchtime learning today. And I'm going to be going live with Brittany Kim, also known as the CRPS PT, who is our CRPS program. Today. We did this last week. It was awesome. And I'm very excited to do it again because of the great questions that have been coming in on CRPS and dystonia. Hi,
Hi,
Brittany.
Julie, and everybody else.
Yeah, we have a great lunchtime crew here. And I see a lot of physios joining us. So thanks for joining us live. This is such an interesting topic. And I think it's one of the topics where I feel like the ortho neuro world comes together, right, Brittany?
Yeah.
And in the topic of CRPS and dystonia. Oh, Olivia's here. Let's talk about CRPS and functional neurologic
Hi,
disorders. Thanks
Olivia.
for coming. Yeah, I feel like people literally are waving to us as we see them on here. So, Brittany, why don't you get us started with just kind of talking about how these things can occur together and maybe why this happens?
Yeah, so with CRPS, people think of CRPS primarily as like a pain condition, but people with CRPS can also develop movement disorders, and dystonia is a type of movement disorder that they can have. It is the more common movement disorder you might see in someone with CRPS as well. And then I think, Julie, you were going to link one of the studies that talked about this in the newsletter. And it's really interesting because they looked at a group of people with CRPS and tried to understand what were the more common types of movement disorders, when it was more prevalent, different things like that. And with dystonia and CRPS, you might more commonly see this in children. So they found that around like children with CRPS age 11 was a more common time that they were seeing dystonia. And that's definitely been my personal experience in the clinic. Is oftentimes I've seen adolescents and younger children who also have dystonia with CRPS. That doesn't mean adults can't experience that too. And I also want to be clear that not everyone with CRPS is going to have a movement disorder. A lot of people that I've seen don't have other types of movement disorders. They just have a slowing of movement, or kind of like it's mainly due to pain. It's like, I don't want to move because it hurts, and that's very logical. And then slowly the brain adapts as a protective mechanism to slow or cease movement of the limb. For dystonia in particular, I did try to do a little bit more of a literature review to see if there's any updates on this. But I think the main kind of like theory behind it is that there are essentially neuroplasticity changes happening at the spinal cord level. So the type of dystonia you'll more commonly see in CRPS is what would be called a fixed dystonia. And if in the arm, it'll look like the arm is curled in. In the foot, it'll be in that kind of pointed down and then inward position. I think, Julie, you posted like a picture of an example. That's really common to see that almost exact presentation. And part of that might be due to, they theorize what's called the withdrawal reflex. So if you were, for example, to touch a hot stove, you pull your arm away, right? Or if you were to step on like a sharp object, you'd pull your foot away. And there's this kind of automatic response that we have to those types of painful stimuli. And as part of kind of like the changes, what happens is there's like reduced inhibition coming from the brain. So the brain's like not telling the action from the spinal cord to like do what it needs to do. And then there's changes peripherally that take place to kind of encourage more flexor activity like that. So that's kind of the current theory. I would say there's probably, I'd love to see if there's more fMRI studies specifically studying this, but CRPS is a small population, and then dystonia is a small population, and then dystonia and CRPS is an even smaller population. So it's, I think it would be really interesting to see more of that overlap and more of what's happening on the brain side of things. But in general, there's some sort of reconnecting, and there's like this disinhibition, and it's not sending a message down to the body to say, you don't have to do that response, basically. Yeah.
I love that that explanation of it, actually. And that's also we've talked about this other article as well, which, as Brittany mentioned, every week, if you're a clinician, on Fridays, I put together the videos from the week and put articles that we've referenced all week. You can sign up at reactiveeducation.com. And if you're a person with CRPS or dystonia or functional neurologic disorders, we send that out on Mondays, and you can sign up at reactivept.com. One of the articles that we've shared before is that Popkirov is the main author. And I think what's interesting about this, and this is why when we teach in our dystonia mini course, or in our complex case masterclass, or in Brain Bites together, we kind of talk about some of these overlapping mechanisms for many of these disorders, where there's these neuroplastic changes in the brain. Some things are peripherally mediated and have more input, like from the spinal cord, for example, like that withdrawal reflex. But I find it fascinating that in functional dystonia, or the presentation of functional dystonia, is often almost exactly like CRPS. So it's a fixed, often, now not all of the time, I've seen all kinds, but often a fixed dystonia of the hands, or a fixed dystonia of the foot. And that picture that I shared in the post today was actually a side-by-side, somebody with CRPS, fixed dystonia, next to somebody with a functional neurologic disorder, fixed dystonia. And in that article by Popkirov, he talks about these central and peripheral mechanisms that we might see in both CRPS and in FND, and why we might see components of both in those presentations. And I think that's really interesting. But here's the thing, when we do ask why, like a lot of neurologic disorders, we don't fully know. And I teach this at USC. I teach neuropathology, and many weeks we're teaching, like, here are some proposed mechanisms for everything from ALS to Parkinson's to MS, to even things like Guillain-Barré. We know a little bit, but we don't know the full picture. And that's the same with CRPS, and that's the same with dystonia and functional neurologic disorders. We know some. So we get here every week to share some, but that's like all we know. We wish we knew more. Now, Brittany, I'm curious then, people ask a lot from a treatment standpoint then. So if somebody with CRPS does develop dystonia, what are some of the things that you might be thinking about incorporating?
Actually, in that same article that we were talking about earlier that studied dystonia in CRPS, there was a really interesting finding they had about how people who did have these movement disorders also had sensory changes as well. And people either not really feeling the limb, or people feeling the limb too much. And so this is where there's definitely this interplay of sensory motor pieces that I think need to be understood and assessed and then treated. So I would imagine that if you were to examine someone who had this type of dystonia in CRPS, that you would want to understand how are they processing that sensory information. And I would probably venture to say it's probably impaired and that you could treat the sensory side and see if, like, getting a better map of the foot and the limb might help, right? And it might help even drive some of that inhibition and, like, just changing the brain and how it's connecting. I think a lot of the principles from GMI would be really useful, and in particular mirror therapy, because we know there is this kind of like affected motor response to that kind of just like recruitment of all those flexor muscles in that positioning. And then in the clinic, the other thing I have seen and I think is important to think about is how long this person's had dystonia for, because you can also develop biomechanical or, you know, like mobility changes, because they've just been kind of fixed in that position, and our body physically adapts when it doesn't need to stretch that far. It says, okay, I guess we don't need to do that anymore, and then it adapts. So I think in addition to working on sensory motor pieces, then thinking about how can I improve someone's flexibility and mobility. But I would say to just focus on flexibility, mobility, and alone doesn't make sense in this situation, because you have to ask yourself, what's actually driving this problem? And I would venture to say the sensory motor piece is like the biggest piece of our pie in that situation.
Yeah. Yeah, I feel like we should give like an amen to that statement for dystonia even as a whole, because I think when we see people with dystonia, you automatically want to think like, I think we need to stretch that muscle. I think we need to mobilize here. And actually, yes, we do. But that's kind of a secondary piece that has occurred because of the dystonia. It's not the primary issue. There was another thing that you said, and you said it early on, that lack of inhibition from the brain, which is a common mechanism. I talked about that the other day in cervical dystonia. There are studies to show that lack of inhibition is occurring. And so you get this excessive motor drive, which can be assessed and treated sensory motor too. I'm curious also about the autonomic component of that drive. And have you, because we see the autonomic changes in CRPS as well, have you seen that? I know it's not published because I have not found it, but I know it's something that we look at clinically. And have you seen that change for
that's
CRPS
such a good
dystonia?
question. I haven't had someone in a while with dystonia and CRPS to be able to have like tests. I think it's my knowledge of the autonomic nervous system. This is where it comes in. Is like came after seeing some of those people with dystonia and CRPS, and I wouldn't be surprised if that would be helpful. I guess that's all I could say is like, I think it's worth exploring. I do feel though that's where like the testing matters, right? Like assessing the autonomic nervous system, maybe doing a little trial of like, what if we tinker with the autonomic nervous system? Does it change the dystonia? I have this feeling though that sensory motor component might be like the bigger driver, and then the autonomic nervous system is kind of like a little perpetuator that like is creating more challenges for the recovery process, I guess, if that makes sense.
Yeah, no,
Yeah.
that makes great sense. Clearly, by the way, I don't send any questions to Brittany.
Yeah.
I'm always just like, what do you, but let me tell you, this is how Brittany and I function. We just
Yeah.
get curious about things and we go, I wonder. So here's a little like peek into our brains right now. Like, this is how
Careful.
we think, like, be careful,
Yeah.
you might go down a
Yeah.
rabbit hole. But we wanted to keep some of these things really just kind of spontaneous, and like we're talking about these topics for you all. But I think about this a lot in particular because I think this could be some of the distinguishing characteristics of a functional dystonia without CRPS. I have found that maybe there is there's definitely a sensory and motor piece of the pie. This is the universal symbol for pie, by the way.
I know mine goes this way, I think. There
is a piece that's sensory motor, but I think there is potentially more autonomic component to that as well. And so I think sometimes when folks maybe feel like stuck or not sure where to go, or there's so much sensitivity sensory wise that there's not a lot that seems like you can accomplish. You may need to go in through kind of the back door of the autonomic nervous system
Yeah.
to help regulate, help improve some of the inhibition and drive that's happening peripherally.
Mm-hmm.
But I also haven't seen that in CRPS. I have seen it in functional dystonia.
And in that PopCure article, I'm just thinking of like another piece of that pie is they were talking a lot about that overlap of physical injury being like a common mechanism. And I'd be curious about that relationship of physical injury to functional dystonias. And then because CRPS, the most common onset is some sort of physical something like trauma or injury. So yeah, that would be really interesting to understand too. Mm-hmm.
Yeah, we need to do a lot of studies.
Yeah, I know. I know. Yeah.
But Gail, hi Gail. Gail's asking some great questions. So
Yeah.
I have a patient with both cervical dystonia and CRPS and a functional gait disorder. I'm wondering how you dose mirror therapy and how much do you do? Is it based on an increase in pain or tolerance or something else?
Yeah, so it's almost like you need a couple different mirrors on different parts of the body in the situation. This may be really dependent on like I think the different parts of the body might respond differently is kind of what I would imagine. And then thinking about I don't know where the CRPS is, but for like focusing on that piece at least, dosing it, your limiting factor is always going to be someone's pain levels because we don't want to push beyond a point that might create this opportunity for a flare-up. It's important to challenge the nervous system, but finding that challenge point, I think, is the first step. And part of that is a little experimental because each person is unique. And then my best advice is to always put the ball in the person you're working with in their court. So building autonomy, that gives them the opportunity to start learning firsthand. Okay, yes, I can actually push myself a little bit more, or, oh, I need to start reeling it back. So they get the chance to actually figure out for themselves and with you together what some of those limits are. And then that allows you together to push forward towards their goals that they have for themselves.
Yeah.
I hope that's helpful.
I think that's so helpful. And I was thinking back to our brain bite session with Mike this week, and that was like such a theme of the patient being able to drive that. And I think that's so helpful with some of these techniques for CRPS. And okay, Gail, I feel like we're going to just do a little session with you here because she's also asking, and you know what, these are great questions because I think other folks will ask them too. Let me go back up here. The dysautonomia or maybe the autonomic changes in CRPS. So Brittany, are the erythema or vascular changes that we often see in the limbs considered part of the autonomic changes?
Yeah, so there's correct, or like if someone's out there, you can correct me if I'm wrong with the terminology. For some reason my brain is like trying really hard to put the words together. I think the term is called afferent sympathetic coupling or afferent. So basically the inputs from the periphery and the sympathetic nervous system, there is this coupling that takes place, and that's one of the mechanisms that we believe may contribute to things like the color changes, the temperature changes. And when we think about how the autonomic nervous system works, a big driver is, or one of the things it does is it changes the vessel, right? Like it constricts it or it dilates it, right? And so neurologically, that's like the little light switch that's telling it what to do. And so it makes sense that if there's this weird kind of new way of existence that you're going to be seeing these different unusual changes in color, and we can appreciate people who don't have CRPS but have vascular conditions, like that's why that differential diagnosis is really important, is like knowing like, okay, yes, like that those color changes are related to that. I think that should be
Yeah.
helpful. And then the Popcurov article is from 2019. I think Julie said she's going to put it in the newsletter. So if you're not in the
Yeah.
newsletter, you should sign up for it.
And I
And
put a
then,
little screenshot, Gail, in the post from today of the article. It's called CRPS Syndrome and F&D Time for Reconciliation, too, in case you can't wait for the newsletter
yeah.
today. I often can't wait. Yep. So she said she has ankle CRPS, which is probably contributing to gait disorder.
Yeah.
And she started putting the ball back in her court. Yay. Because you are amazing, and such a great therapist. We have so many great therapists in our community, and I'm very thankful for the types of questions that people ask that get us curious too. And I know we probably need to wrap up because we could talk about this.
I know.
And I think we both have something coming up right now. So I just wanted to thank you for keep sharing and keep the questions coming on these topics. Brittany and I are going to keep jumping in here. I'm going to tell you to go give Brittany a follow at the CRPS PT because this is her love, and she has so many great just insights and nuggets to share on her Instagram too. And if you're also going, what do I do in dystonia? We have a mini course on dystonia. Chelsea Richardson and I recorded this course. It's on demand. It's 2 hours of learning for clinicians. It's on sale this week until November 8th. So you can get it at a great price, get all of our resources. Go check that out if you're a clinician, or send it to your therapist. If you have a great therapist who's like, I'm ready to learn about dystonia, that's how I started. That's how we all started, right? We didn't get this in school. So go get that course. It's at reactiveeducation.com/dystonia. And I see one more question here. So we'll take one more question.
Last one.
It's important to identify triggers to prevent relapse of CRPS. And how do you go about determining those triggers if they are psychological or emotional triggers? Wow, what a good question.
It is.
Yeah.
I think the word relapse is where I could see a couple different words coming in. So some people with CRPS go into remission. And in some cases, they really they stay in remission because they stay active. They have a great medical management team, and then they have a rehab team that's like off in the wings if they ever need something. And sometimes CRPS can recur, but it's because the times I've seen it is like, oh, I stepped off a curb and twisted my ankle. Like, something happens again and everything restarts. Like there's another injury. So as far as like a trigger goes, some of those are not really preventable because life happens. And I think the solution is, one, not being fearful, like I can't ever leave my house again. It's like, no, you should do the things that you love, right? Like you have to go out there and be in the world and do what you love. I think building a support team, like if you're a person with CRPS, this is who I'm talking to, you should build a support team for yourself, a really great physical therapist, a good medical management team, and bringing back into the psychological emotional triggers. If you're someone where you find that those are a part of what you need to take care of for symptom management, then having a wonderful psychologist who really understands your condition and supports you well will, I think, really prevent a lot of flare-ups that may happen, and also just really aid you in your recovery process. Some of those things take longer, those sides of things. And so it's important, I think, to have a good team that you can always rely on, not always have to be with, but like if something comes up, they're there for you to support.
Yeah. That's great. And Brittany, actually, I ran into somebody that you've worked with a few times for CRPS in toe and foot.
Mhm.
And I ran into her like at a coffee shop, and she was like, you know, because I've been through the rehab process, when I sprained my ankle again, I knew what I needed. I knew that she even used these words that my sensory map might get smudged. I knew that I still needed to keep moving, but I might need to do X, Y, and Z because that's what my body needed. And I think that's one of the most powerful things about kind of going through and working with a
Mhm.
team approach for
Mhm.
CRPS is that you learn so much about your brain, your body, and what you need, so that I hope you go skiing again and hurt your ankle. Like, I mean, I'd rather you not hurt your ankle, but I hope that you're doing things and you might end up injuring it because you feel the freedom and you know, okay, if I do this, this is what I need to do
Mhm.
this is what my brain and body, the good old like rice, elevate and all of those things might not be what I need to do. I need to do something differently. And the power of knowing that is worth so many things. So I think we'll end on that because I think there's a lot of hope for folks with
Mhm.
CRPS.
Mhm.
Um, and I just want to thank Brittany for bringing a lot of that knowledge to us too. Yeah.
Well, thanks for having me, Julie.
Yeah. Thank you, Brittany. And thank you, everybody else. Have a great day.
Bye.
Bye.